Hello and welcome to Chapter 13. In this chapter we will be reviewing fluid and electrolyte balance and disturbances. Please review the glossary and familiarize yourselves with the terms, especially look at osmolality, osmosis, homeostasis, diffusion, and tonicity. As a reminder, this may be a longer than usual lecture, so please pause and take a break as needed. Fluid and electrolyte balance is a dynamic process that is crucial for life in homeostasis. Potential and actual disorders of fluid and electrolyte balance occur in every setting, with every disorder, and with a variety of changes that affect healthy people, such as increased fluid and sodium loss with strenuous exercise and high environmental temperatures. Also, inadequate intake of fluid and electrolytes. As nurses, we want to help try to prevent these, and if they do occur, we want to be able to treat those fluid and electrolyte imbalances or Approximately 60% of a typical adult's weight consists of fluid, which is water and electrolytes. Factors that influence the amount of body fluid are age, gender, and body fat. In general, younger people have a higher percentage of body fluid than older people, and men have proportionately more body fluid than women. Of course, those people who are obese have less fluid than those who are thin because the fat cells contain very little water. The skeleton also has low water content. Muscle, skin, and blood contain the highest amount of water. Body fluid is located in two fluid compartments: the intracellular space, which is the fluid in the cells, and the extracellular space, which is the fluid outside of the cells. The ECF, or extracellular fluid compartment, is further divided into intravascular, interstitial, and transcellular fluid spaces. The intravascular space, which is that fluid within the blood vessels, contains plasma, the effective circulating volume. Approximately 3 liters of the average 6 liters of blood volume in adults is made up of plasma. The 3 liters is made up of erythrocytes, leukocytes, and thrombocytes. For your interstitial space, this contains fluid that surrounds the cell and totals about 11 to 12 liters in an adult. Lymph is an interstitial fluid. The transcellular space is the smallest division of the ECF compartment and contains approximately 1 liter. Examples of these include your cerebrospinal fluid, pericardial, synovial, intraocular, and pleural fluids such as your sweat and digestive secretions. Circulatory and neurologic symptoms, physical examination findings, and laboratory test results can be used to identify the compartment from which the fluid has been lost. Body fluids normally move between two major compartments or spaces in an effort to maintain equilibrium between those spaces. Loss of fluid from the body can disrupt the equilibrium. Sometimes fluid is not lost from the body, but it is unavailable for use by either the interstitial fluid or the extracellular fluid. Loss of the ECF into a space that does not contribute to the equilibrium between the ICF and the ECF is referred to as that third spacing fluid shift, or also known as third spacing. Early evidence of a third space fluid shift is a decrease in urine output despite adequate fluid intake. Urine output decreases because the fluid shifts out of the intravascular space to then receive less blood and attempt to compensate by decreasing that urine output. Other signs and symptoms of third spacing that indicate an intravascular fluid volume deficit include increased heart rate, decreased blood pressure, decreased central venous pressure, edema, increased body weight, and imbalances in fluid intake and output. Note that third space shifts occur in patients who have hypocalcemia, decreased iron intake, severe liver diseases, alcoholism, hypothyroidism, malabsorption, immobility, burns, and cancer. Electrolytes in the body fluids are active chemicals. These contain cations that carry positive charges and anions that carry negative charges. The major cations in body fluid are sodium, potassium, calcium, magnesium, and hydrogen ions. The major anions are chloride, bicarbonate, phosphate, sulfate, and protonate ions. These chemicals unite in varying combinations. Therefore, electrolyte concentration in the body is expressed in terms of milliequivalents per liter. This is a measure of chemical activity rather in terms of milligrams, a unit of weight. Electrolyte concentrations in the ICF differ from those in the ECF. You can refer to Table 13-1 that gives you your approximate major electrolyte content in the body cells. Because special techniques are required to measure electrolyte concentrations in the ICF, it is customary to measure the electrolytes in the most accessible portion of the ECF, namely the plasma. Sodium ions, which are positively charged, far outnumber the other cations in the ECF. Because sodium concentration affects the overall concentration of the ECF, sodium is important in regulating the body volume fluid. Retention of sodium is associated with fluid retention, and excessive loss of sodium is usually associated with decreased volume of body fluids. As shown in Table 13-1, which is in your text on page 239, the major electrolytes in the ICF are potassium and phosphate. The ECF has a low concentration of potassium and can tolerate small changes in potassium concentrations. Therefore, release of large stores of intracellular potassium, typically caused by trauma to the cells and tissues, can be extremely dangerous. Normal movement of fluids through the capillary wall into the tissue depends on the hydrostatic pressure. This is the pressure exerted by the fluid on the walls of the blood vessel at both arterial and venous ends of the vessel, and the osmotic pressure exerted by the protein of plasma. The direction of fluid movement depends on the differences in these two opposing forces. So you want to look at hydrostatic versus osmotic. So when we look at that regulation of fluid, again, your hydrostatic pressure is exerted on the walls of the blood vessels, whereas your osmotic is exerted by the protein in the plasma. The direction of fluid also depends on the differences in those pressure points. When we look at osmosis and osmolality, when two different solutions are separated by a membrane that is impermeable to the dissolved substances, fluid shifts through the membrane from the region of low solute concentration to the region of high solute concentration until the solute is equal in concentration. This diffusion of water caused fluid concentration gradient is known as osmosis. The number of dissolved particles contained in a unit of fluid determines the osmolality of the solution, which influences the movement of fluid between the fluid compartments. Tonicity is the ability of all solutes to cause an osmotic driving force that promotes water movement from one compartment to another. There are three terms that are associated with osmosis. You have osmotic pressure, oncotic pressure, and osmotic diuresis. Osmotic pressure is the amount of hydrostatic pressure needed to stop the flow of water by osmosis. It is primarily determined by the concentration of solutes. Oncotic pressure is the osmotic pressure exerted by proteins, such as your albumin. When we look at osmotic diuresis, this is the increase in urine output caused by the excretion of substances such as glucose, mannitol, or contrast agents in the urine. Diffusion, this is the natural tendency of a substance to move from an area of higher concentration to one of lower concentration. It occurs through the random movement of ions and molecules. Filtration, on the other hand, we look at hydrostatic pressure in the capillaries. This tends to filter fluid out of the intravascular compartment into the interstitial fluid. Movement of water and solutes occur from an area of high hydrostatic pressure to an area of low hydrostatic pressure. Note that the kidneys filter approximately 180 liters of plasma per day. Another example of filtration is the passage of water and electrolytes from an arterial capillary bed to an interstitial fluid. In this instance, the hydrostatic pressure results from the pumping action of the heart. When we look at active transport, note that that physiologic pump that moves fluid from the area of lower concentration, higher concentration, and do pay attention when you're deciphering between osmosis, osmolality, diffusion, and filtration. Again, looking at active transport, talking a little bit about sodium-potassium pump. The sodium concentration is greater in the ECF than in the ICF. Because of this, sodium tends to enter the cell by diffusion. This tendency is offset by the sodium-potassium pump that is maintained by cell membrane and actively moves sodium from the cell into the ECF. Conversely, the high intracellular potassium concentration is maintained by pumping potassium into the cell. By definition, active transport implies that energy must be expended for the movement to occur against a concentration gradient. So note that filtration is a type of passive transport that results from that hydrostatic pressure. As nurses, you guys must be careful to avoid confusing this pressure with energy expenditure during active transport of sodium out of the cell by the sodium-potassium pump. It can get a little confusing, so do know the difference of that hydrostatic pressure, whereas you're dealing with your sodium and the sodium-potassium pump. So those are clarified when it talks about filtration and your sodium-potassium pump. And of course, all of this requires energy, and if you remember that from back in the day in one of your various A&P classes, we need that ATP to provide that energy. Here's a true or false statement in regards to osmosis. That statement is false, and here's the rationale. Now, let's look at some routes of gains and losses. Water and electrolytes are gained in various ways. Healthy people gain fluids by drinking and eating, and their daily average I and O of water are approximately equal. When we look at the kidneys, the usual daily urine volume in an adult is about 1 to 2 liters. A general rule is that the output is approximately 1 ml of urine per kilogram of body weight per hour. And that is in all age groups. When we look at the skin, sensible perspiration refers to the visible water and electrolyte loss through the skin, such as sweating. The chief solutes in sweat are sodium, chloride, and potassium. Actual sweat losses can vary from 0 to 1,000 mLs or more every hour depending on the factors such as the environmental temperature. Continuous water loss by evaporation, approximately 500 mLs a day, occurs through the skin as insatiable perspiration, which is that non-visible form of water loss. Fevers greatly increase the initial water loss through the lungs and the skin, as does the loss of the natural skin barrier, which happens if any major burns occur. When looking at the losses, we talked about the kidneys and urine output and through the skin. Looking at the lungs, they normally eliminate water vapor, which is also an insensible loss at a rate of approximately 300 mLs per day. The loss is much greater with increased respiratory rate or depth or in a very dry climate. When we look at the gastrointestinal tract, the usual loss through the GI tract is 100 to 200 mLs daily, even though approximately 8 liters of fluid circulates through the GI system every 24 hours. Because the bulk of fluids is normally absorbed in the small intestine, diarrhea and fistulas can cause large losses. And here's a question about urinary output in an adult. And here's the answer with the rationale. And now I just want to point out a couple of illustrations in your book. And the first one goes over the physiology or pathophysiology of the fluid regulation cycle, ADH, antidiuretic hormone, your BP, which is your blood pressure, your ECF or your extracellular fluid, and your GFR or your glomerular filtration rate. Just review this, and you don't have to memorize it and know which goes where. Just kind of look over it, and that is also found in your text on page 243. Here we find another illustration that is also found in your text on page 244, which goes over the physiology and the pathophysiology of your ANP, which is the role of your atrial natriuretic peptide in the maintenance of fluid balance. Again, you do not have to memorize this or the flow of the chart. It is just for your visual illustration there. And here we'll talk a little bit about our gerontological considerations. Of course, with everything, we will consider our elderly population. So normal physiologic changes of aging including reduced cardiac, renal, and respiratory function, and reserve and alternations in the ratio of body fluids to muscle mass may alter the responses of older people to fluid and electrolyte changes and the acid-base disturbances. In addition, the use of multiple medications by older adults can affect renal and cardiac function, thereby increasing their likelihood of fluid and electrolyte disturbances. Routine procedures such as your vigorous administration of laxatives or enemas before colon X-ray studies may produce a serious volume deficit, necessitating the use of intravenous fluids to prevent hypotension and other effects of hypovolemia. Alteration in fluid and electrolyte balance that may produce minor changes in young and middle-aged adults may produce profound changes in older adults. In many older patients, the clinical manifestations of fluid and electrolyte disturbances may be subtle or even atypical. Dehydration is the rapid loss of more than 3% of body weight owing to the loss of either water or sodium. Dehydration in older adults is common because of the decreased kidney mass, decreased glomerular filtration rate, decreased renal blood flow, decreased ability to concentrate urine, inability to conserve sodium, decreased excretion of potassium, and decreased total body water. Loss of subcutaneous supporting tissue and resultant thinning of the skin occurs with age. The dermis is dehydrated and loses strength and elasticity. These skin changes affect the placement of peripheral IV catheters in older adults, which we will talk about when we get to the IV portion. Now, before we go forward and talk about fluid volume imbalances and disturbances, I want to back up just a little bit and review a couple of laboratory tests that are useful when evaluating fluid status. So, of course, we talked about osmolality and osmolarity. Know the difference that your osmolality is the concentration of fluid that affects the movement of water between fluid compartments by osmosis. It measures the sodium concentration per kilogram in the body or in the blood and the urine. It also measures a solution's ability to create osmotic pressure and affect the movement of water. So when we look at labs that we may expect when we're looking to evaluate that fluid volume, we want to look at the serum osmolality and the urine osmolality. This is the most reliable indicator of urine concentration. In healthy adults, your normal serum osmolality is 270 to 300. Osmolarity, in turn, this is another term that describes the concentration of solutions, and it is measured in milliosmoles per liter. The value of osmolarity is usually within 10 of the value of the osmolality. Now, of course, I will not have you calculating the osmolality and seeing what the deficit is, but that is good to know that we would look at the patient's serum osmolality to get a good indicator of that urine concentration. Also, you would look at the urine specific gravity. This measures the kidney's ability to excrete or conserve water. The specific gravity of urine is compared to the weight of distilled water, which has a specific gravity of 1.000. The normal range of urine specific gravity is 1.010 to 1.025. This can be measured at bedside by placing a calibrated urometer in the cylinder of approximately 20 mL of urine. Specific gravity can also be assessed with a refractometer or a dipstick with a reagent for this purpose. Note that it varies with the urine volume. Normally, the larger the volume of urine, the lower the specific gravity is. So don't be fooled. Specifically is a less reliable indicator of the concentration than the urine osmolality. Increased glucose or protein in the urine can cause a falsely elevated specific gravity. Factors that increase or decrease urine osmolality are the same as for those for urine-specific gravity. Also, a couple of other labs that you may pay attention to when looking at that fluid status and electrolytes. You want to look at the BUN and the creatinine. Those are two that are sensitive to renal function and actually seeing, if the patient is urinating enough, how their I's and O's are actually looking. Looking at some of the homeostatic mechanisms, again, we'll look at the kidneys. Vital to regulation of fluid and electrolyte balance, the kidneys normally will filter 180 liters of plasma every day in the adult and then excrete that 1 to 2 liters of urine. They act both autonomously and in response to blood-borne messengers such as your aldosterone and your antidiuretic hormone, or your ADH. Major functions of the kidneys in maintaining normal fluid balance include regulation of the ECF volume, regulation normal electrolyte levels in the ECF, and then regulation of pH of the ECF by retention of the hydrogen ions, and lastly, excretion of metabolic waste and toxic substances. Heart and blood vessel function. The pumping of the heart circulates blood through the kidneys under sufficient pressure to allow for urine formation. Failure of this pumping action interferes with renal perfusion and thus with water and electrolyte regulation. Looking at the lungs again, these are also vital to maintaining homeostasis. Through exhalation, the lungs remove approximately 300 ml of water daily in the normal adult. Abnormal conditions such as hyperpnea or abnormal deep respiration or continuous coughing increase this loss. Mechanical ventilation with excessive moisture decreases it. The lungs also play a major role in maintaining that acid-base balance that we will talk about shortly. When we look at the pituitary functions, the hypothalamus manufactures ADH, which is stored in the posterior pituitary gland and released as needed to conserve water. When we look at adrenal functions, aldosterone, which is a mineral corticoid secreted by the zona glomerulosa, which is your outer zone of the adrenal cortex, has a profound effect on fluid balance. Increased secretion of aldosterone causes sodium retention and thus water retention and potassium loss. Conversely, decreased secretion of aldosterone causes sodium and water loss and potassium retention. Cortisol, which is another adrenocortical hormone, has less mineralocorticoid actions. However, when secreted in large quantities or administered as corticosteroid therapy, it can also produce sodium and fluid retention. As for your parathyroid hormones, your parathyroid glands embedded in the thyroid gland regulate calcium and phosphate balance by means of parathyroid hormone, or your PTH. This influences bone reabsorption, calcium absorption from the intestines, and calcium reabsorption from the renal tubules. Looking at those other mechanisms, first we'll look at baroreceptors. These are located in the left atrium and the carotid and aortic arches. These receptors respond to changes in the circulating blood volume. They regulate sympathetic and parasympathetic neural activity as well as your endocrine activities. The outcome is an increase in cardiac rate, conduction, and contractility, and an increase in the circulating blood volume. We'll also look at the antidiuretic hormone and how it relates to thirst. So your antidiuretic hormone, or ADH, and the thirst mechanism have important roles in maintaining sodium concentration and oral intake of fluids. Oral intake is controlled by the thirst center located in the hypothalamus. As serum concentration or osmolality increases or blood volume decreases, Neurons in the hypothalamus are stimulated by the intracellular dehydration. Thirst then occurs, and the person increases his or her intake of oral fluids. Water excretion is controlled by ADH, aldosterone, and baroreceptors, as mentioned previously. The presence or absence of ADH is the most significant factor in determining whether the urine that is excreted is concentrated or dilute. And last, we'll look at the natriuretic peptides. The natriuretic peptide hormones affect fluid volume and cardiovascular function through the excretion of sodium, direct vasodilation, and the opposition of the renin-angiotensin-aldosterone system. 4 peptides have been identified. We won't go into all of them, but I did want to mention that little tidbit of information. And now we'll go into the fluid volume imbalances. First, we will take a look at hypovolemia, or your fluid volume deficit. This occurs when the loss of the ECF volume exceeds the intake of fluid. It occurs when water and electrolytes are lost in the same proportion as they exist in normal body fluids. Thus, the ratio of serum electrolytes to water remains the same. Fluid volume deficit should not be confused with dehydration, which refers to the loss of water alone with increased serum levels. Fluid volume deficit may occur alone or in combination with other imbalances. Unless other imbalances are present concurrently, serum electrolyte concentrations remain essentially unchanged. So this results from the loss of body fluids and occurs more rapidly when coupled with decreased fluid intake. It can also develop with a prolonged period of inadequate intake. Causes of fluid volume deficit include abnormal fluid losses, such as those resulting from vomiting, diarrhea, GI suctioning, and sweating. Decreased intake, as in nausea or lack of access to fluids, and third spacing fluid shifts, or that movement of fluid from the vascular system to other body spaces. Additional causes include diabetes insipidus, which is that decreased ability to concentrate urine owing to a defect in the kidney tubules that interferes with water reabsorption, adrenal insufficiency, osmotic diuresis, hemorrhage, and even a coma. So again, those are some of your causes and some of your risk factors for dehydration. And again, do not confuse your dehydration with your fluid volume deficit. So when we look at clinical manifestations, they can develop rapidly, and its severity depends on the degree of fluid loss. Clinical signs and symptoms and laboratory findings are presented in your text in a very nice detailed table starting on page 246, table 13-4. When we look at assessment of the laboratory data, this is useful in evaluating your fluid volume status. Again, these will include your BUN and its relation to the serum creatinine concentration. A volume depleted patient has a BUN elevated out of proportion to the serum creatinine. The ratio is usually greater than 20 to 1. The BUN can be elevated because of dehydration or decreased renal perfusion and function. The presence and cause of hypovolemia may be determined through the health history and physical exam. Serum electrolyte changes may also exist. Potassium and sodium levels can be reduced, such as hypokalemia, hyponatremia, or elevated, such as hyperkalemia or hypernatremia. It gives you a few examples in your text on page 245 as in when these would occur, such as your hypokalemia would occur with your gastrointestinal and renal losses versus your hypernatremia, which is your excess of sodium that would result from an increase of insensible losses and with your diabetes insipidus. Note that the urine-specific gravity is increased in relation to the kidneys' attempt to conserve water and is decreased with diabetes insipidus. Aldosterone is secreted when fluid volume is low, causing reabsorbed sodium and chloride, resulting in decreased urine sodium and chloride. Your urine osmolality can be greater than 400 millimoles per kilogram because the kidneys try to compensate by conserving that water. Normal laboratory values for the data that we just covered can be found in Appendix A online. When we look at managing that fluid deficit, there are a few things that can be done. When planning the correction of fluid loss for the patient with fluid volume deficit, the primary provider considers the patient maintenance requirements and other factors such as fever that can influence fluid needs. If the deficit is not severe, the oral route is preferred, provided that the patient can drink. However, if fluid losses are acute or severe, the IV route is required. Isotonic electrolyte solutions, such as your lactated Ringer's or your normal saline, or should I say 0.9% sodium chloride, what we call normal saline, are frequently the first line of choice to treat the hypotensive patient with fluid volume deficit because they expand the plasma volume. As soon as the patient becomes normotensive, a hypotonic electrolyte solution, such as your half normal saline, is often used to provide both electrolytes and water for renal excretion of metabolic waste. Accurate and frequent assessments of the INO, weight, vital signs, central venous pressure, level of consciousness, breath sounds, and skin color should be performed to determine when therapy should be slowed to avoid that volume overload from occurring. Here again, we will discuss and make sure that even if the patient is on PO fluids, that we are taking those accurate I's and O's, and that we're teaching the patient how to write down or document what they're taking in and how often or how much they are urinating when they're going to the bathroom. Of course, we will be assessing that skin turgor and monitoring those mucous membranes and their level of consciousness or mental status. I also want to look at if the patient actually has severe fluid volume deficit and they are not excreting urine or enough urine, and therefore they're what we call oluric, or they have oliguria. The primary provider needs to determine whether the depressed renal function is caused by reduced renal blood flow secondary to the fluid volume deficit. The test used This type of situation is referred to as a fluid challenge. An example of a typical fluid challenge test involves administering 100 to 200 milliliters of normal saline solution over a 15-minute period. The goal is to provide fluids rapidly enough to attain adequate tissue perfusion without compromising the cardiovascular system. The response by the patient is fluid volume deficit, but normal renal function is increased urine output and an increase in blood pressure and central venous pressure. Note that shock can occur when the volume of fluid loss exceeds 25% of the intravascular volume or when fluid is lost too rapidly. So to assess that fluid volume deficit, you as the nurse would monitor and measure their, of course, I's and O's at least every 8 hours. Some, depending on their severity of fluid volume deficit, may be getting measured every 4 hours. If they're on particular medications, they may even be monitored hourly when it comes to their I's and O's. As fluid volume deficit develops, fluid losses exceed fluid intake through excessive urination, which is that polyuria, diarrhea, vomiting, or other mechanisms. Once fluid volume deficit has developed, kidneys attempt to conserve body fluids, leading to a urine output less than that 1 milliliter per kilogram per hour in the normal adult. Urine in this instance is very concentrated and represents a healthy response. Daily weights are monitored, and an acute loss of 0.5 kilograms, which is your 1 pound, represents a fluid loss of approximately 500 mLs, which is 1 liter of fluid. That weighs approximately 1 kilogram or 2.2 pounds. Please monitor your patient's vital signs. As the nurse, you want to observe for a weak, rapid pulse and orthostatic hypotension. A decrease in body temperature often accompanies fluid volume deficit unless there is a concurrent infection. Skin and tongue turgor, which we rarely check tongue turgor, are monitored on a regular basis. So in a healthy person, pinched skin immediately returns to the normal position when it is released. Tissue turgor is the best measure by pinching the patient's skin right over the sternum, the inner aspects of the thighs, or even the forehead. Tongue turgor is not affected by age, and evaluating this may be more valid than evaluating the skin turgor, although it's rarely done. The degree of mucous membrane moisture is also assessed. Note that a dry mouth may indicate either deficit or someone who is mouth breathing. Urine concentration is monitored by measuring the urine-specific gravity. In a volume-depleted patient, the urine-specific gravity should be greater than 1.020, indicating a healthy renal conservation of fluid. You also want to note the mental function that is or can be eventually affected, resulting in delirium if the patient has severe fluid volume deficit, and this is as a result of decreasing cerebral perfusion. Of course, to prevent that hypovolemia, you as the nurse must identify patients that are at risk and take measures to minimize fluid losses. For example, if your patient has diarrhea, measures should be implemented to control that diarrhea and replace fluids needed. When we look at correcting that hypovolemia when possible, of course, you want to promote those oral fluids. Those are administered to help correct that fluid volume deficit with consideration given to the patient's likes and dislikes. Of course, if they absolutely hate water, which, some people do, although I don't know how they survive without it, we can add things to it like a little bit of juice. They have all sorts of things now that You can add to your water to give it pretty much a little flavor if you don't like water. Um, and we wouldn't want to give the patient, tea if they didn't like tea. So please pay attention to their likes and dislikes, because of course if you give them fluids that they do not normally drink or will not drink, then you're still going to have the issue. So you do want to note that if the deficit cannot be corrected by those oral fluids, then initiating an alternative route, usually your IV route, will be the answer until adequate circulating blood volume and renal perfusion is achieved. And of course, your isotonic fluids are prescribed to increase that extracellular fluid volume. In your text on page 248, it goes over the selected water and electrolyte solutions. You don't have to know this by heart or even try to memorize it, because it gets very complicated pretty much. Just kind of look over it and see what's used for what deficits or what electrolyte imbalances uses which solutions. And it's a pretty good detailed chart, and again, it's in your text on page 248. Here we will look at a question regarding extracellular fluid volume deficit. And here's the answer with the rationale. And now we look at fluid volume access. So fluid volume access, or what we call hypervolemia, refers to an isotonic expansion of the ECF caused by the abnormal retention of water and sodium in approximately the same proportions in which they normally exist in the extracellular fluid. It is most often secondary to an increase in the total body sodium content, which in turn leads to an increase in total body water. Because there is isotonic retention of body substances, the serum sodium concentration remains essentially normal. When we look at some of those risk factors that contribute to this, heart failure, renal failure, and cirrhosis of the liver, those are contributing factors. Another contributing factor is the consumption of excessive amounts of table or other sodium salts. So we like to warn or educate, I wouldn't say warn people, we like to educate them on putting extra salt on your foods. Most foods, when they're prepared, already have salt on them. Even if they're freshly grown, they have some type of sodium in them. So we usually tell people not add extra sodium, because it can lead to that fluid volume access. The clinical manifestations of fluid volume access result from the expansion of the extracellular fluid and may include edema, distended neck veins, and crackles, which are your abnormal lung sounds. When we look at laboratory data and diagnostic findings, this is useful in diagnosing your fluid volume access. We'll look at the BUN and the hematocrit levels. With fluid volume access, both of these values may be decreased because of the plasma dilution, low protein intake, and anemia. In chronic renal failure, both serum osmolality and the sodium level are decreased owing to excessive retention of water. The urine sodium level is increased if the kidneys are attempting to excrete excess volume. A chest x-ray may reveal pulmonary congestion. Hypervolemia occurs when aldosterone is chronically stimulated. Therefore, the urine sodium level does not increase in these conditions. When we look at medical management, This is directed at the causes, and if related to excessive administration of sodium-containing fluids, discontinuing the infusion may be all that is needed. Symptomatic treatment consists of administering diuretics and restricting fluids and sodium. When we look at the pharmacologic therapy, diuretics are prescribed when dietary restriction of sodium alone is insufficient to reduce that edema by inhibiting the reabsorption of sodium and water by the kidneys. The choice of diuretic is based on the severity of hypervolemic state, the degree of impairment of renal function, and the potency of the diuretic. Thiazide diuretics block sodium reabsorption in the distal tubule, where only 5 to 10% of filtered sodium is reabsorbed. Loop diuretics such as your Lasix, your Bumex, or your Demodex can cause a greater loss of both sodium and water because they block the sodium reabsorption in the ascending limb of the Henle's loop, where 20 to 30% of the filtered sodium is normally reabsorbed. Electrolyte imbalances may result from the diuretic. Hypokalemia can occur with all diuretics except those that work in the last distal tubule of the nephrons. Potassium supplements can be prescribed to avoid this complication. Hyperkalemia can occur with diuretics that work in the distal tubule, especially in patients with decreased renal function. Hyponatremia occurs with diuresis owing to increased release of that ADH secondary to reduction in the circulating volume. You can have decreased magnesium levels with the administration of loop and thiazide diuretics due to the decreased reabsorption and increased excretion of magnesium by the kidney. When we look at that fluid volume access and nursing management, we want to, of course, pretty much follow the same idea. Before we look at nursing management, I want to talk a little bit about nutritional therapy, because when we're treating that fluid volume excess, this usually involves dietary restriction of sodium. Hence why I said do not add extra salt to your food. An average daily diet not restricted in sodium contains about 6 to 15 grams of salt, whereas a low sodium diet can range from a mild restriction to little as 250 milligrams of sodium per day, depending on the patient's needs. A mild sodium restricted diet allows only light salting of food, about a half of the usual amount in cooking and at the table, and no addition of salt to commercially prepared foods that are already seasoned. Foods high in sodium must be avoided. It is the sodium salt or sodium chloride rather than the sodium itself that contributes to edema. Therefore, patients are instructed to read food carefully to determine that salt content. Because about half of the ingested sodium is in the form of seasoning, seasoning substitutes can play a major role in decreasing that sodium intake. Of course, we can recommend lemon juice, onions, garlic. These are all excellent substitute flavorings, although some patients prefer salt substitutes. Most salt substitutes contain potassium and must therefore be used cautiously by patients that are taking potassium-sparing diuretics. They should not be used at all in conditions associated with potassium retention, such as advanced renal disease. Salt substitutes containing ammonium chloride can be harmful to patients also with liver damage. Now, in some communities, drinking water may contain too much sodium for a sodium-restricted diet. Depending on its source, Water may contain as little as 1 milligram or more than 1,500 milligrams of sodium per quart. That's some salty water. Patients may need to find or use distilled water if the local water supply is very high in sodium. Bottled water can have a sodium content that ranges from 0 to 1,200 milligrams per liter. Therefore, if sodium is restricted, the label must be carefully examined for sodium content before purchasing and drinking bottled water. So now looking at that nursing management. To assess for fluid volume test, the nurse measures I&Os at regular intervals and identifies excessive fluid retention. The patient is weighed daily and rapid weight gain is noted. An acute weight gain of 1 kilogram or 2.2 pounds is equivalent to a gain of approximately 1 liter of fluid. Breath sounds are assessed at regular intervals in at-risk patients, particularly if parenteral fluids are being administered. The nurse monitors the degree of edema in the most dependent parts of the body, such as the feet, ankles, and the legs, in ambulatory patients, and in the sacral region of patients confined to the bed. Pitted edema is assessed by pressing the finger to the affected part, creating a pit or indentation that is evaluated on a scale of 1 plus, which is minimum, to 4 plus, which is severe. Peripheral edema is monitored by measuring the circumference of the issue with a tape marked in millimeters. Of course, we want to make sure we're preventing hypovolemia. Patients are instructed for that those over-the-counter medications without first checking with the healthcare provider, because these substances may also contain sodium. If fluid retention persists despite adherence to a prescribed diet, hidden sources of sodium such as the water supply or use of water softeners should also be considered. When we look at educating our patients about edema and fluid volume access, because edema is common, we must educate our patients about this. Edema can occur as a result of increased capillary fluid pressure, decreased capillary oncotic pressure, or increased interstitial oncotic pressure, causing expansion of the interstitial fluid compartment. Edema can be localized or generalized. Severe generalized edema is called anasarca. Another thing I want to talk about before you move forward is ascites, and you may be familiar with this. Ascites is a type of edema in which fluid accumulates in the peritoneal cavity. It results from nephrotic syndrome or cirrhosis and some malignant tumors. The patient commonly reports shortness of breath and a sense of pressure because of the pressure on the diaphragm. The goal of treatment is to preserve or restore circulating intravascular fluid volume. Thus, in addition to treating the cause of edema, other treatments may include diuretic therapy, restriction of fluids and sodium, elevation of the extremities, application of anti-embolytic stockings, paracentesis, dialysis, and continuous renal replacement therapy in cases of renal failure or life-threatening fluid volume overload. Here we will discuss electrolyte imbalances. This will go through a series of 6 imbalances, both the high and the low, for sodium, potassium, calcium, magnesium, phosphorus, and chloride. Alright, so Now we'll take a look at hypernatremia. This is when your serum sodium level is higher than 145 milliequivalents per liter. It can be caused by a gain of sodium in excess water or by a loss of water in excess of sodium. It can occur in patients with normal fluid volume or in those with fluid volume deficit or excess. With the water loss, the patient loses more water than sodium. As a result, the serum sodium concentration increases, and the increased concentration pulls fluid out of the cell. This is both an extracellular and intracellular fluid volume deficit. In sodium excess, the patient ingests or retains more sodium than water. A common cause of hypernatremia is fluid deprivation in unconscious patients who cannot perceive, respond to, or even communicate their thirst. Administration of hypertonic enteral feedings without adequate water supplements leads to hypernatremia, and does watery diarrhea and greatly increase insensible water loss, that of hyperventilation and burns. In addition, diabetes insipidus can lead to hypernatremia if the patient does not experience or cannot respond to thirst, or if the fluids are excessively restricted. Some of your less common causes of hypernatremia are your heat stroke, near drowning in seawater, and malfunction of hemodialysis or peritoneal dialysis systems. When you look at the clinical manifestations, these are owing to the increased plasma osmolality caused by an increase in plasma serum concentration. Water moves out of the cell into the ECF, resulting in cellular dehydration and a more concentrated ECF. Clinical signs and symptoms, as well as laboratory findings, again are documented in chart 13 or table 13-4 within your text. Dehydration is often overlooked as the cause of mental status and behavioral changes in the older adult population. Body temperature may increase mildly, but it returns to normal after the hypernatremia is corrected. The primary characteristic of natremia will be thirst. Thirst is such a strong defender of serum sodium levels in healthy people that hypernatremia never occurs unless the patient is unconscious or does not have access to water. However, those who are ill and older patients may have an impaired thirst mechanism, so that is also something to remember. When we look at medical management, this consists of gradual lowering of the serum sodium level by infusion of hypotonic electrolyte solutions, which is your 0.3 sodium chloride. And again, you will not have to remember all of these solutions that you have to administer, especially for these imbalances, because it can get quite tricky. So you to administer that hypotonic electrolyte solution. There is no consensus about the exact rate at which serum sodium levels should be reduced. As a general rule, the serum sodium level is reduced at a rate no faster than 0.5 to 1 milliequivalent per liter. Along with using that hypotonic solution, you can also use a isotonic non-saline solution such as your D5W. That's indicated when water needs to be replaced without the actual sodium. Clinicians need to consider a hypotonic solution to be safer than the D5W because it allows a gradual reduction in the serum sodium level, thereby decreasing the risk of cerebral edema. Desmopressin acetate, or your DDAVP. This is a synthetic ADH, and it may be prescribed to treat diabetes insipidus if it is the cause of the hypernatremia. Looking at nursing management, as in hyponatremia, fluid losses and gains are carefully monitored in patients who are at risk for hypernatremia. The nurse should assess for abnormal losses of water or low water intake and for large gains of sodium, as might occur with ingestion of over-the-counter medications that have a high sodium content, such as your Alka-Seltzers. In addition, the nurse obtains a medication history because some prescription medications may have a high sodium content as well. The nurse also notes the patient's thirst or elevated body temperature and evaluates it in relation to the other signs and symptoms. As a nurse, you also need to monitor for changes in behavior, such as restlessness, disorientation, and lethargy. As the nurse, you want to attempt to prevent hypernatremia by providing oral fluids at regular intervals, particularly in the debilitated patients who are unable to receive or respond to thirst. For those patients with diabetes insipidus, adequate water intake is and must be ensured. If the patient is alert and has an intact thirst mechanism, merely providing access to water may be sufficient. When parenteral fluids are necessary for managing hypernatremia, the nurse has to monitor the patient's response to fluids by reviewing the serum sodium levels and by observing for changes in neurologic stats. With a gradual decrease in serum sodium, the neurologic signs should also improve. Too rapid reduction in serum sodium level renders the plasma temporarily hypoosmotic. Now we will shift towards looking at potassium. So potassium is that major intercellular electrolyte. In fact, 98% of the body's potassium is inside of the cells. The remaining 2% is in the extracellular fluid and is important in neuromuscular function. It influences both skeletal and cardiac muscle activity. To maintain potassium balance, the renal system must function because 80% of the potassium excreted daily leaves the body by way of the kidneys. The other 20% is lost through the bowel and in sweat. So first we'll look at hypokalemia. This is a serum potassium level below 3.5, and your normal serum potassium concentration ranges are from 3.5 to 5. So your hypokalemia is any level below 3.5 milliequivalents per liter, and this usually indicates that deficit in total potassium. However, it may occur in patients with normal potassium stores. When alkalosis is present, a temporal shift of serum potassium into the cells also occurs, which we will look at when we discuss those acid-base imbalances. So potassium-losing diuretics, such as your thiazides and your loop diuretics, can induce hypokalemia. Vomiting and gastric suctioning frequently lead to hypokalemia, partly because potassium is actually when gastric fluid is lost, and because potassium is lost through the kidneys in response to metabolic alkalosis. Alterations in acid-base balance have significant effects on the potassium distribution due to shifts of hydrogen and potassium ions between the cells and the extracellular fluid. Patients who do not eat a normal diet for a prolonged period are at risk for hypokalemia. When we look at the clinical manifestations, potassium deficiency can result in widespread derangements in the physiologic function. Severe hypokalemia can cause death through cardiac or respiratory arrest. Clinical signs develop when the potassium level decreases to less than 3. Clinical signs and symptoms are also found in your table 13-4. If prolonged, hypokalemia can lead to an inability of the kidneys to concentrate, causing dilute urine, resulting in polyuria and nocturia, and also excessive thirst. Potassium depletion suppresses the release of insulin and results in glucose intolerance. When we look at the assessment and diagnostic findings, in hypokalemia, the serum potassium concentration is less than the lower limit of normal. EKG changes include or can include flat T waves or inverted T waves or even both, suggesting ischemia, and ST segments. An elevated U wave is specific to hypokalemia. The source of potassium loss is usually evident from a careful history. However, if cause of the loss is unclear, a 24-hour urine potassium excretion test can be performed to distinguish between renal and extrarenal loss. Urinary potassium excretion exceeding 20 milliequivalents per day with hypokalemia suggests that renal potassium loss is the cause. When we want to manage hypokalemia, it cannot be prevented by conventional measures such as an increase in, if it cannot be prevented by that conventional measure such as the increase in daily dietary intake or by oral potassium supplements for deficiencies, then it can be treated cautiously with IV replacement. Potassium loss must be corrected daily. Administration of 40 to 80 milliequivalents per day of potassium is adequate in the adult if there are no abnormal losses of potassium. For patients who are at risk for hypokalemia, a diet containing sufficient potassium should also be provided. Dietary intake of potassium in the average adult is about 50 to 100 milliequivalents per day. So some of your foods that are high in potassium content include most fruits, in particular oranges, melons, and bananas, vegetables, legumes, whole grains, milk, and meat. Also included in there are your whole natural fruit juices. When dietary intake adequate for any reason, oral or IV potassium supplements may be prescribed. Many salt substitutes contain about 50 to 60 milliequivalents of potassium per teaspoon and may be sufficient to prevent hypokalemia. If oral administration of potassium is not feasible, the IV route is indicated. The IV route is mandatory for patients with severe hypokalemia, which is that level less than 2 or less. Although potassium chloride, KCl, is usually used to correct potassium deficits, potassium acetate or potassium phosphate may also be prescribed. When we look at the nursing management, because it can be life-threatening, as the nurse you need to monitor for its early presence in patients at risk. Fatigue, anorexia, muscle weakness, decreased bowel motility, paresthesias, dysrhythmias, these are all signals that warrant assessing the serum potassium concentration. Prevention may involve encouraging the patient at risk to eat foods rich in potassium if their diets allow it. Again, those that are rich are your fruit juices, bananas, melons, citrus, fruits, fresh and frozen vegetables, lean meats, milk, and whole grains. Careful monitoring of fluid I&O is necessary because 40 milliequivalents of potassium is lost for every liter of urine output. Also, you want to monitor those ECG changes, especially if administering IV potassium. Caution must be used when selecting a premixed solution containing KCl, as the concentration ranges from 10 to 40 milliequivalents per 100 mL. Renal function should be monitored through the BUN and creatinine levels, and urine output if the patient is receiving potassium replacement. During replacement therapy, the patient is monitored for signs of worsening hypokalemia as well as hyperkalemia. You also want to know if your patient is getting IV potassium replacement. It is never, ever IV push or intramuscular, and this is to avoid replacing potassium too quickly. It must, and I repeat, it must be placed on an IV pump. Also, one alert that you want to know is that if you're giving the patient oral potassium supplements, they can produce small bowel lesions. Therefore, the patient must be assessed for and cautioned about abdominal distended pain or even GI bleeding. So when we look at hypokalemia, there's a lot of education that comes in with that, and the patient has to adhere to these things, especially if we're counting on them to follow the dietary intake. Now we will look at the other end of the spectrum, which is hyperkalemia. So with hyperkalemia, those are your serum potassium levels greater than 5 milliequivalents per liter. And in the older adult, there is an increased risk for hyperkalemia due to the decreases in the renin and aldosterone, as well as increased number of comorbid cardiac conditions. Like okalemia, hyperkalemia is often caused by iatrogenic or treatment-induced causes. Although hyperkalemia is less common than hypokalemia, it is usually more dangerous because cardiac arrest is more frequently associated with high serum potassium levels. So your major causes of hyperkalemia are decreased renal excretion of the potassium, rapid administration of potassium, and movement of potassium from the ICF compartment to the ECF compartment. When we look at those clinical signs and symptoms and laboratory findings, again, they can be summarized in your text in Table 13-4. The most important consequence of hyperkalemia is its effect on the myocardium. Cardiac effects of elevated serum potassium are usually not significant when the level is less than 7. However, they are almost always present when the level is 8 or greater. As the plasma potassium level rises, disturbances in cardiac conduction occur. The earliest changes, often occurring at serum potassium levels greater than 6, are peak narrow T waves, ST segment depression, and a shortened QT interval. If the serum potassium level continues to increase, the PR interval becomes prolonged and is followed by disappearance of the P waves. Finally, there is a decomposition and widening of the QRS complex. Ventricular dysrhythmias and cardiac arrest may also occur. So serum potassium levels and ECG changes are crucial to the diagnosis of hyperkalemia as discussed previously. Also, our arterial blood gases may reveal both metabolic and respiratory acidosis, which we will cover shortly. When we look at our medical management, the ECG be obtained immediately to detect any changes. In non-acute situations, restriction of dietary potassium and potassium-containing medications may correct the imbalance. Administration either orally or by retention enema of cation exchange resins may be necessary. Note that K-exalate binds with other cations in the GI tract and contributes to the development of hypomagnesemia and hypocalcemia. It may also cause sodium retention and fluid overload and should be used with caution in patients with heart failure. If serum potassium levels are dangerously elevated, it may be necessary to administer IV calcium gluconate. Within minutes after administration, calcium antagonizes the action of hypercalcemia on the heart but does not reduce the serum potassium concentration. Calcium chloride and calcium gluconate are not interchangeable. Calcium blue contains 4.5 milliequivalents of calcium, and calcium chloride contains 13.6 milliequivalents of calcium. Therefore, caution is required. Monitoring the blood pressure is essential to detect hypotension, which may be a result from the rapid IV administration of calcium gluconate. IV administration of sodium bicarb may be necessary in severe metabolic acidosis to alkalinize the plasma, shift potassium into the cells, and furnish sodium to antagonize the cardiac effects. Circulatory overload and hypernatremia can occur when large amounts of hypertonic sodium bicarb are given. IV administration of regular insulin and a hypertonic dextrose solution causes a temporary shift of potassium into the cells. Glucose and insulin therapy has an onset of action within 30 minutes and lasts for several hours. Beta-2 agonists such as your albuterol or Proventil or Venlafaxine are highly effective in decreasing potassium. However, their use remains controversial because they can cause tachycardia and chest discomfort. They move potassium into the cells and may be used in the absence of ischemic heart disease. Further looking into hyperkalemia, we look at the nursing management. So patients at risk for potassium excess need to be identified and closely monitored for signs of hyperkalemia. As the nurse, you want to monitor the iron and observe for signs of muscle weakness and dysrhythmias. When measuring vital signs, an apical pulse should also be taken. The presence of paresthesias and GI symptoms such as nausea and interstitial colic are noted. Serum potassium levels as well as the BUN, creatinine, glucose, and arterial blood gas values need to be monitored for patients at risk for developing hyperkalemia. Measures are taken to prevent hyperkalemia in patients at risk when possible by encouraging patients to adhere to prescribed potassium restriction. Potassium-rich foods to be avoided include many fruits, vegetables, legumes, whole grain breads, lean meats, milk, eggs, coffee, tea, and cocoa. Conversely, foods with minimal potassium content include butter, margarine, cranberry juice or sauce, ginger ale, gumdrops or jelly beans, hard candy, root beer, sugar, and honey. Labels on cola beverages must be checked carefully because there are some high in potassium and some are not. As the nurse, you must caution patients to use salt substitutes sparingly if they are taking other supplementary forms of potassium or potassium-conserving diuretics. In addition, potassium-conserving diuretics such as your spironolactone or your aldactone and salt substitutes should not be administered to patients with renal dysfunction. And here's a question regarding the ECG change and hyperkalemia. And here's the answer with the rationale. And now let's look at calcium imbalances. More than 99% of the body's calcium is located in the skeletal system. It is a major component of bones and teeth. About 1% of the skeletal calcium is rapidly exchangeable with blood calcium, and the rest is more stable and only slowly exchanged. The normal total serum calcium is 8.6 to 10.2 milligrams per deciliter. Calcium exists in the plasma in three forms: ionized, bound, and complex. Calcium is absorbed from foods in the presence of normal gastric acidity and vitamin D. It is excreted primarily in the feces, with the remainder excreted in the urine. The serum calcium level is controlled by the parathyroid hormone, pH, and calcitonin. As ionized serum calcium decreases, the parathyroid glands secrete PTH. So looking at hypocalcemia, this is when your serum calcium level is lower than 8.6. It occurs in a variety of clinical situations. A patient may have a total body calcium deficit, but a normal serum calcium level. Older people and those with disabilities who spend an amount of time in bed have an increased risk for hypocalcemia because the bed rest increases the bone absorption. So several factors can cause hypocalcemia, including primary hypoparathyroidism and surgical hypoparathyroidism. Inflammation of the pancreas causes the breakdown of proteins and lipids. It is thought that calcium ions combines with the fatty acids released by lipolysis, forming soaps. As a result of this process, hypocalcemia occurs and is common in pancreatitis. It is common also in patients with renal failure because these patients frequently have elevated serum phosphate levels. Hyperphosphatemia usually causes a reciprocal drop in the serum calcium level. Tetany is the most characteristic manifestation of hypocalcemia and hypomagnesemia. It refers to an entire symptom complex induced by increased neural excitability. Clinical signs and symptoms are caused by spontaneous discharges of both sensory and motor fibers in peripheral nerves, and these again are outlined in your table 13-4. Trovik's sign. This consists of twitching of muscles innervated by the facial nerve when the region that is about 2 centimeters anterior to the earlobe, just below the zygomatic arch, is tapped. Troisseau's sign can be elicited by inflating a blood pressure cuff on the upper arm to about 20 millimeters of mercury above the systolic pressure. Within 2 to 5 minutes, carpal spasms, and adducted thumb, flexed wrist, and metacarpal phalangeal joint extended interphalangeal joints with the fingers together. And these are both illustrated in your text on page 259. These will occur with ischemia of the ulnar nerve. Seizures may occur because hypocalcemia increases irritability of the nervous system as well as the peripheral nerves. Other changes associated with hypocalcemia include mental changes, impaired memory, confusion, delirium, and hallucinations. A prolonged QT interval is seen on the ECG due to prolongation of the ST segment and torsades de pointes, a type of ventricular tachycardia. This also may occur. Respiratory effects with decreasing calcium include dyspnea and laryngeal spasms. Signs and symptoms of chronic hypocalcemia include hyperactive bowel sounds, dry and brittle hair and nails, and abnormal clotting. Osteoporosis is associated with prolonged low intake of calcium and represents a total body calcium deficit, even though the serum calcium levels are usually normal. One other thing I wanted to mention when looking at clinical manifestations, you may also notice that your patients that have burns, especially your severe burns, they may not only start to exhibit third spacing or that fluid shift, they may also exhibit signs and symptoms of hypocalcemia. So it will take a thorough nursing assessment especially when looking for those clinical manifestations. Also, when looking at hypocalcemia, you want to look at the medical management. Acute symptomatic hypocalcemia is life-threatening and requires prompt treatment with IV administration of calcium salt. Parenteral calcium salts include calcium gluconate and calcium chloride. Although calcium chloride produces a significantly higher ionized calcium level than the calcium blue does, it is not used as often because it is more irritating and can cause sloughing of tissue if it actually infiltrates. IV administration of calcium is particularly dangerous in patients receiving digitalis-derived medication because calcium ions exert an effect similar to that of digitalis and can cause digitalis toxicity with adverse cardiac effects. The IV site must be observed often for any evidence of infiltration because the risk of extravasation and resultant cellulitis or necrosis. A normal saline or your 0.9% of sodium chloride solution should not be used with calcium because it increases renal calcium loss. Vitamin D therapy may be instituted to increase calcium absorption from the GI tract. Otherwise, the amount of calcium absorbed may not satisfy the body's calcium requirement. When we look at nursing management, it is important to access for hypocalcemia in those high-risk patients. Seizure precautions are initiated if hypocalcemia is severe. The status of the airway is closely monitored because laryngeal stridor can occur. Safety precautions are taken as indicated if confusion is also present. The nurse must educate the patient with hypocalcemia about foods that are rich in calcium. The nurse must also advise the patient to consider calcium supplements if sufficient calcium is not consumed in the diet. Such supplements should be taken in divided doses with meals. Alcohol and caffeine in high doses exhibit calcium absorption, and moderate cigarette smoking increases urinary calcium excretion. The patient is also cautioned to avoid the overuse of laxatives and antacids that contain phosphorus because their use decreases calcium absorption. And here's an illustration of Trousseau's sign that we talked about a few minutes ago. And I will demonstrate that a little better in class. Now we will look at hypercalcemia, which is to the opposite of hypocalcemia. And this is when your serum calcium is greater than 10.2 milligrams per deciliter. This is a dangerous imbalance when severe. In fact, hypercalcemic crisis has a mortality rate as high as 50% if it's not treated promptly. The most common causes of hypocalcemia are malignancies and hyperparathyroidism. Malignant tumors can produce hypercalcemia by various mechanisms. The excess PTH secretion associated with hyperparathyroidism is increased release of calcium from the bones and increased intestinal and renal absorption of calcium. Bone mineral is lost during immobilization, and sometimes this causes elevation of the total calcium in the bloodstream. Thiazide diuretics can cause a slight elevation in calcium levels because the potentiate the action of PTH on the kidneys, reducing urinary calcium excretion. Vitamin A and vitamin D intoxication, as well as chronic lithium use and theophylline toxicity, can calcium excess. Calcium levels are inversely related to phosphorus levels. Hypercalcemia reduces neuromuscular excitability because it suppresses activity at the neural junction. When we look at these clinical manifestations, they are also described in your table 13-4, and they are proportional to the degree of elevation of the serum calcium levels. The more severe tend to appear when the calcium level is approximately 16 or higher. However, some patients become profoundly disturbed with calcium levels on only 12. These symptoms resolve as the serum calcium levels return to normal. Hypercalcemic crisis refers to an acute rise in serum calcium level up to 17 or higher. Severe thirst and polyuria are often present. Other findings may include muscle weakness, intractable nausea, abdominal cramps, severe constipation, diarrhea, peptic ulcer symptoms, and bone pain. Lethargy, confusion, and coma may also occur. This condition is dangerous and may result in cardiac arrest. Emergency treatment with calcitonin is indicated. Looking at medical management, the therapeutic aims include decreasing serum calcium level and reversing the process causing hypercalcemia. Treatment of the underlying cause, such as chemotherapy for malignancy, partial parathyroidectomy, or hyperparathyroidism, is essential. Calcitonin can be used to lower the serum calcium level and is particularly used for patients with heart disease or renal failure who cannot tolerate large sodium loads. IV administration of your normal saline temporarily dilutes the serum calcium level and increases the urinary calcium excretion by inhibiting tubular reabsorption of the calcium. Administering IV phosphate can cause reciprocal drop in serum calcium. Lasix is often used in conjunction with administration of saline solution. In addition to causing diuresis, Lasix increases calcium excretion. Although it's often overlooked, fluids and medications that contain calcium and dietary sources of calcium should be halted. For your patients with cancer, treatment is directed at controlling the condition by surgery, chemotherapy, or radiation therapy. Corticosteroids may be used to decrease bone turnover and tubular reabsorption for patients with sarcoidosis, myelomas, lymphomas, and leukemias. Patients with solid tumors are less responsive. Then looking at nursing management, as the nurse, you must monitor for hypercalcemia in those high-risk patients. Interventions such as increasing patient mobility and encouraging fluids can help prevent hypercalcemia or at least minimize its severity. Hospitalized patients at risk should be encouraged to ambulate as soon as possible. When encouraging oral fluids, the nurse considers the patient's likes and dislikes. Fluids containing sodium should be administered unless contraindicated because sodium assists with calcium excretion. Patients are encouraged to drink 2.8 to 3.8, which is 3 to 4 quarts of fluid daily. Adequate fiber in the diet is encouraged to offset the tendency for constipation. Safety precautions are implemented as necessary when altered mental status is present. The patient and family are informed that mental changes are reversible with treatment. Increased calcium increases the effects of digitalis, therefore the patient is assessed signs and symptoms of digitoxicity. Because ECG changes can occur, the cardiac rate and rhythm are monitored for any abnormalities that may occur. Now we will look at magnesium imbalances. Of course, your magnesium is an abundant intracellular cation. It acts as an activator for many intracellular enzyme systems and plays a role in both carbohydrate and protein metabolism. The normal rate for your magnesium is 1.3 to 2.3. Approximately one-third of the serum magnesium is bound to protein. The remaining two-thirds exist as free cations. So, of course, we will look at the deficit, which is hypomagnesemia, and this is any level below 1.3, and that's frequently associated with hypokalemia and hypocalcemia. Magnesium is similar to calcium in two aspects. It is ionized fraction of magnesium that is primarily involved in neuromuscular activity and other physiological processes, and magnesium levels should be elevated in combination with albumin levels. Because about 30% of magnesium is protein bound, principal lead to albumin, a decreased serum albumin level can reduce the measured total magnesium concentrations. However, it does not reduce the ionized plasma magnesium concentration. An important route of magnesium loss is the GI tract, such as loss that can occur with a nasogastric suction, diarrhea, or even fistulas. Because fluid from the lower GI tract has a higher concentration of magnesium than the fluid of the upper tract, losses from diarrhea and intestinal fistulas are more likely to that magnesium deficit than those from gastric suctioning. Chronic alcohol abuse is a major cause of symptomatic hypomagnesemia in the U.S. The serum magnesium level should be measured at least every 2 to 3 days in patients undergoing withdrawals from alcohol. The level may be normal on admission but may decrease as the result of metabolic changes such as the intracellular shift of magnesium associated with IV glucose administration. During nutritional replacement, the major cellular electrolytes move from the serum to newly synthesized cells. Therefore, if the enteral or parenteral feeding formula is deficient in magnesium content, serious hypomagnesemia will occur. Magnesium deficiency often occurs in diabetic ketoacidosis, secondary to increased renal excretion during osmotic diuresis and shifting of magnesium into the cells with insulin therapy. Other causes include administration of certain medications and citrated blood. For your clinical signs and symptoms and laboratory findings, again, these can and will be found in Table 13-4. Some of your clinical manifestations are due to low serum magnesium level, others are due secondary to changes in potassium and calcium. Symptoms do not usually occur until the serum magnesium level has dropped less than 1. Trophic sign and Trosu sign occur in part because of accompanying hypocalcemia. Hypomagnesemia may be accompanied by marked alteration in cyclostatus. Apathy, depressed mood, apprehension, and extreme agitation have been noted, as well as ataxia, dizziness, insomnia, and confusion. At times, delirium, auditory or visual hallucinations, and frank psychosis may also occur. Magnesium deficiency can disturb the ECG by prolonging the QRS, depressing the ST segment, and predisposing to cardiac dysrhythmias such as premature ventricular contractions, SVT or your supraventricular tachycardia, Desaut's des Pointes, a form of ventricular tachycardia, and ventricular fibrillation. So looking at the medical management, mild magnesium deficiency can be corrected by diet alone. Principal dietary sources of magnesium include those green leafy vegetables, nuts, seeds, legumes, whole grains, seafood, peanut butter, and cocoa. If necessary, magnesium salts can be administered orally in an oxide or gluconate form, place continuous losses, but can produce diarrhea. Patients receiving parenteral nutrition require magnesium on or in the IV solution to prevent hypomagnesemia. Calcium gluconate must be readily available to treat hypocalcemic tetany or hypermagnesemia. Of course, monitoring urine output is essential before, during, and after magnesium administration. The physician is notified if the urine decreases to less than 100 mL over 4 hours. Note that IV magnesium sulfate must be administered by an IV pump as well, and the rate must not exceed 150 milligrams per minute or 67 milliequivalents over 8 hours. Looking at the nursing management for hypomagnesemia, of course, the nurse, you must be aware of those patients at risk. Patients receiving DIG are monitored closely because of a deficit of magnesium can predispose them to DIG toxicity. If it is severe, seizure precautions need to be implemented. Other safety precautions must be instituted as well if confusion is observed. Because difficulty in swallowing may occur in these with magnesium depletion, these patients should be screened for dysphagia as well. Patient education plays a major role in treating magnesium deficits, and the patient is educated about sources of magnesium-rich foods, which again include those green leafy vegetables, nuts, legumes, bananas, and oranges. Now looking at the other end of the spectrum, hypermagnesemia, or that level higher than 2.3, is a rare electrolyte abnormality because the kidneys efficiently excrete magnesium. A serum magnesium level can appear falsely elevated if blood specimens are allowed to hemolyze or drawn from an extremity with a tourniquet that was applied too tightly. By far the most common cause of hypermagnesemia is renal failure. It can occur in patients with untreated diketoacidosis when catabolism causes the release of cellular magnesium that cannot be excreted because of the profound fluid volume depletion and resulting oliguria. Look at the clinical manifestations. Acute elevation of serum magnesium levels depresses the central nervous system as well as the peripheral neuromuscular junction. Again, those signs and symptoms are summarized in table 13-4. The respiratory center is depressed when the serum magnesium level exceeds 10. Coma, atrioventricular heart blocks, and cardiac arrest can occur if the serum magnesium level is greatly elevated and not treated. High levels of magnesium also result in platelet clumping and delayed thrombin formation. When we look at medical management, this can be prevented by the administration of magnesium to patients with renal failure and by carefully monitoring seriously ill patients who are receiving magnesium salts. If patients with severe hypermagnesemia, all parenteral and oral magnesium salts are discontinued. In emergencies such as respiratory depression or defective cardiac conduction, ventilatory support and IV calcium gluconate are indicated. Patients at risk should, of course, be identified. If it is suspected, you as the nurse must monitor vital signs, noting any hypotension or shallow respirations, observe for decreased deep tendon reflexes or your DTRs, and changes in the level of consciousness. Medications that contain magnesium are not administered to patients with renal failure or compromised renal function, and patients with renal failure are cautioned to check with their healthcare providers before taking any over-the-counter medications. Caution is usually essential when preparing and administering magnesium-containing fluids parenterally because available parenteral magnesium solutions differ in concentration. IVs. Here we will look at phosphorus imbalances. This is a critical constituent of all body tissues. It is essential to the function of muscle and red blood cells, the formation of adenosine triphosphate or your ATP, and 2,3-diphosphoglycerine. This facilitates the release of oxygen from hemoglobin and the maintenance of acid-base balance, as well as the nervous system and intermediary metabolism of carbohydrate, proteins, and fat. It provides the structural support to bones and teeth as well. So first we'll look at hypophosphatemia, which is indicated at a level below 2.5. And note that your normal levels are between 2.5 and 4.5 minutes. So although it often indicates phosphorus deficiency, hypophosphatemia may occur under a variety of circumstances in which total body phosphorus stores are normal. So it may occur during the administration of calories to a patient with severe protein calorie malnutrition. It is most likely to result from an overzealous intake or administration of simple carbohydrates. Marked hypophosphatemia may develop in a malnourished patient who received parenteral nutrition if the phosphorus loss is not corrected. Excess phosphorus binding by acids may decrease the phosphorus available from the diet to an amount lower than the required to maintain phosphorus balance. Most of the signs and symptoms result from the deficiency of ATP and your 2,3-diphosphoglycerine, or both. Your ATP deficiency impairs cellular energy resources, whereas the other deficiency impairs oxygen delivery to its tissues, resulting in a wide range of neurologic manifestations. Again, those clinical signs and symptoms are summarized in your table 13-4. Muscle damage may develop as the ATP level in the muscle tissue declines, and clinical manifestations are muscle weakness, which may be subtle or profound and may affect any muscle group, muscle pain, and at times acute rhabdomyolysis, which is your breakdown of skeletal muscle. Weakness of respiratory muscles may greatly impair ventilation. Hypophosphatemia may predispose a person to insulin resistance and thus hyperglycemia. When we look at medical management, of course, prevention is the goal. In patients at high risk, serum phosphate levels should be closely monitored. Severe phosphatemia is dangerous and requires prompt attention. Aggressive IV phosphorus correction is usually limited to a patient whose serum phosphorus levels decrease to less than 1 and whose GI tract is not functioning. Possible effects of IV administration of phosphorus include tetany from hypocalcemia and calcification in the tissues from the hyperphosphatemia. IV preparations of phosphorus are available as sodium or potassium phosphate. The rate of phosphorus administration. Now we switch gears and look at hyperphosphatemia, which is that level that exceeds 4.5. Various conditions can lead to this, however, the most common is renal failure. Other causes include increased intake, decreased output, or a shift from the intracellular extracellular space. Conditions such as excessive vitamin D intake, administration of total parenteral nutrition, chemotherapy for neoplastic disease and hypoparathyroidism, metabolic or respiratory acidosis, ketoacidosis, acute hemolysis, high phosphate intake, profound muscle necrosis, and increased phosphorus absorption may also lead to phosphorus imbalance. Clinical signs and symptoms are summarized again in Table 13-4. Most symptoms result from the decreased calcium levels in the soft tissue calcification. The most important short-term consequence is tetany. Because of the reciprocal relationship between phosphorus and calcium, a high serum phosphorus level tends to cause a low serum calcium concentration. The major long-term consequence is soft tissue calcification, which occurs mainly in patients with reduced glomerular filtration rates. High serum levels of inorganic phosphorus promote precipitation of calcium phosphate and in non-osseous sites, decreasing urine output, impairing vision, and reducing palpitations. When we look at that medical management, when possible, treatment is indicated or directed at underlying disorders. For example, if they have hyperphosphatemia, this may be related to volume depletion or respiratory or metabolic acidosis. So you want to treat those underlying causes. Surgery may be indicated for the removal of large calcium and phosphorus deposits if they are not taken care of. When we look at nursing management, of course, again, you want to identify those patient risks. If a low phosphorus diet is prescribed, the patient is instructed to avoid phosphorus-rich foods such as cheeses, creams, nuts, meats, whole grain cereals, dried fruits, dry vegetables, kidneys, sardines, sweetbreads, and foods made with milk. When appropriate, the nurse should instruct the patient to avoid phosphate-containing laxatives and enemas. Also, the nurse must educate the patient about reorganizing or recognizing the signs of impending hypocalcemia and monitoring for changes in urine output. The last imbalance that we will discuss is chloride. This is a major anion of the ECF and is found more in the interstitial and lymph fluid compartments than in the blood. It is also contained in the gastric and pancreatic juices, sweat, bile, and saliva. Looking at hypochloremia, this is when your chloride is below 97, noting that your normal levels are between 97 and 107. This can occur with GI tube drainage, gastric suctioning, gastric surgery, and severe vomiting and diarrhea. Administration of chloride deficient IV fluids, low sodium intake, decreased serum sodium levels, metabolic alkalosis, massive blood transfusions, diuretic therapy, burns, and fever may all be causes of hypochloremia. Administration of aldosterone, TH, corticosteroids, bicarbonate, or laxative decreases serum chloride levels as well. Signs and symptoms are summarized again in Table 13-4, and the signs and symptoms of hyponatremia, hypokalemia, and metabolic alkalosis may also be present. Metabolic alkalosis is a disorder that results in a high pH and a high carbonate level, which we will discuss shortly, with compensation of partial pressure of carbon dioxide in the arterial blood. This increases to 50 millimeter mercury. Hyperexcitability of muscles, tetany, hyperactive, deep tendon reflexes, weakness, twitching, and muscle cramps may result. Hypokalemia can cause hypochloremia, resulting in cardiac dysrhythmias. When we look at medical management, treatment involves correcting the cause and contributing electrolyte and acid-base imbalances. Normal saline or half-strength normal saline is administered IV to replace the chloride. If the patient is receiving a diuretic, it may be discontinued or another diuretic may be prescribed. Ammonium chloride, an acidified agent, may be prescribed to treat metabolic alkalosis. The dosage will depend on the patient's weight and serum chloride level. This agent is metabolized by the liver and its effect lasts for about 3 days. Its use should be avoided in patients with impaired liver or renal function. When we look at the nursing management, of course, you want to monitor the I's and O's, arterial blood gas values, and the serum electrolyte levels. Changes in the patient's level of consciousness and muscle strength and movement are reported to the physician promptly, as well as vital signs, making sure you assess that respiratory status. Those will be carried out frequently. You will provide and educate the patient about foods that are high in chloride content, which include tomato juice, bananas, dates, eggs, cheese, milk, salty broth, canned vegetables, and processed meats. A person who drinks free water, water without electrolytes, or bottled water, and excretes large amounts of chloride needs to be instructed to avoid drinking this type of water. And lastly, hyperchloremia, which is your excess of chloride greater than 107. With hypernatremia, bicarbonate loss, and metabolic acidosis can occur with high chloride levels. They are almost exclusively as a result of the aerogenically induced hyperkalemic metabolic acidosis stemming from excessive administration of chloride to sodium, most commonly your normal saline solution, your half normal saline solution, or your lactated. This condition can also be caused by loss of bicarbonate ions by the kidney or the GI tract with corresponding increase in chloride ions. The signs and symptoms are the same as those of metabolic acidosis, which is your hypolemia, hypernatremia, tachypnea, weakness, lethargy, deep and rapid respirations, diminished cognitive ability, and hypertension can occur. If it is left untreated, it can lead to a decrease in cardiac output, dysrhythmias, and even a coma. A high chloride level is accompanied by a high sodium level and fluid retention. When you look at the medical management, of course, correct line cause and restoring electrolyte, fluid, and acid-base balance are essential. Hypotonic IV solutions may be administered to restore that balance. LR, or your lactated ringer solution, may be prescribed to convert lactate to bicarbonate in the liver, which increases bicarbonate levels and corrects that acidosis. As the nurse, you want to monitor those vital signs, your atrial blood gases, and eyes and nose. Assessment findings related to respiratory, neurologic, and cardiac findings should also be documented, and changes should be discussed with the physician. You also want to educate the patient about the diet that should be followed in order to manage that hyperkalemia and maintain adequate hydration. Now we will switch gears and talk a little bit about acid-base balance. We will do a few activities within class that should solidify the information for you, but you want to note that acid-base disturbances are commonly encountered in clinical practice, especially in your critical care units. So we will discuss both of them. Well, there's that we will discuss. We will talk about the differences in them and the levels that we should look for. This just briefly goes over your acid-base balance, talking about your buffer systems, your ECF and your ICF, which we explained at the beginning of the chapter, and how they all work together. Again, we won't go too in depth when we talk about the acid-base balances, so I will tell you or point out the important facts that we need to look at and discuss when it comes to the acid-base balance. I won't take you all the way back to chemistry class and make you understand the actual process, but when you are working in that critical care area, it will be something that you will come to understand and know like the back of your hand. And here's a question in regards to the most common buffer system. And here's the answer and the rationale. Now, the first one that we will talk about is metabolic acidosis. The information that is found on your slides or within your next few slides will be basically the important information that I wanted to point out. And I also want you to know that it is a common clinical disturbance characterized by that low pH and a low plasma bicarbonate concentration. And in your text on page 271, most important chart, table 13-7, which goes over your normal values for arterial and mixed venous bloods. So it will go pH, which you will need to know, your bicarb, which is HCO3, and then also the other one that we will point out is your PaCO2, which is also listed in that chart. And we will be looking at the arterial blood as far as the values go. So that again in your text on page 271. And again, we will do some activities in class that will pretty much pull it all together, because reading it can sometimes be very confusing as to how it will look if you actually drew blood gases on your patient. So with metabolic acidosis, the normal anion gap acidosis results from the direct loss of bicarb, as in diarrhea, your lower intestinal fistulas, your urostomies, and the use of diuretics, early renal insufficiency, excessive administration of chloride, and administration of parenteral nutrition without bicarb or bicarbonate producing solutes such as lactate is how this actually occurs or results. When we look at the high anion gap acidosis, this usually results from excessive accumulation of acid. You won't have to know the differences between the two. Again, in class we will go over some very basic acid-base imbalances, and you'll have a better understanding of them. Looking at the clinical manifestations, signs and symptoms of metabolic acidosis will vary with the severity of the acidosis, but they can include headache, confusion, drowsiness, increased respiratory rate and death, nausea, and vomiting. Peripheral vasodilation and decreased cardiac output occur when the pH drops to less than 7. Additional physical assessment findings include decreased blood pressures, cold and clammy skin, dysrhythmias, and shock. Chronic metabolic acidosis is usually seen with chronic renal failure. Here is some additional information in regards to metabolic acidosis. And now we'll look at metabolic alkalosis. This is a clinical disturbance characterized by a high pH, which will be your pH greater than 7.5, and a high plasma bicarbonate concentration, which is that bicarb greater than 26. It can be produced by a gain of bicarb or a loss of hydrogen. A common cause is vomiting or gastric suction with loss of hydrogen and chloride ions. Hypokalemia produces alkalosis in two ways. Either the kidneys conserve potassium and therefore the hydrogen excretion increases, or the cellular potassium moves out of the cells and into the extracellular fluid in an attempt to maintain the near normal serum levels. Alkalosis is primarily manifested by symptoms related to decreased calcium ionization, such as tingling of the fingers and toes, dizziness, hypertonic muscles. The ionization of calcium decreases in alkalosis as more calcium combines with serum proteins. Respirations are depressed as a compensatory action by the lungs. Atrial tachycardia may occur as the pH increases and hypokalemia develops. Ventricular dysrhythmias or disturbances may also occur. Symptoms of the chronic metabolic alkalosis are the same as for the acute metabolic alkalosis, and as the potassium decreases, frequent premature ventricular contractions or U waves are seen on the ECG. And again, here is some additional information in regards to your metabolic alkalosis. And now we talk briefly about respiratory acidosis. And this is a clinical disorder in which the pH is less than 7.35 and the PaCO2 is greater than 42. And a compensatory increase in the plasma HCO3 actually occurs. It may be either acute or chronic. Again, we won't distinguish between the two. Some of the clinical signs that you may see, of course, they will vary between your acute and chronic. Sudden hypercapnia, which is your elevated PaCO2, can cause increased pulse and respiratory rates, increased blood pressure, mental cloudiness or confusion, and a feeling of fullness in the head or a decrease in the level of consciousness. An elevated PaCO2 greater than 60 causes cerebrovascular vasodilation and increased cerebral blood flow. Ventricular fibrillation may be the first sign of respiratory acidosis in anesthetized patients. If respiratory acidosis is severe, intracranial pressure may increase, resulting in papilledema and dilated conjunctival blood vessels. Hyperkalemia may result as the hydrogen concentration overwhelms the compensatory mechanisms of hydrogen, and hydrogen will move into the cell, causing a shift of the potassium out of the cell. And if it is chronic, the body may try to compensate, and we will talk a little bit about compensation shortly. Again, a little more information on respiratory acidosis, and of course your treatment is aimed at improving that ventilation. Now we will look at respiratory alkalosis, and this is a clinical condition in which the arterial pH is greater than 7.45 and the PaCO2 is less than 38. As with respiratory acidosis, acute and chronic can occur. It is always caused by hyperventilation, which causes excessive blowing off of CO2 and hence a decrease in the plasma carbonic acid concentration. Causes include extreme anxiety, hypoxemia, early phase aspirin intoxication, gram-negative bacteremia, and inappropriate ventilator settings. Chronic can result from chronic hypocapnia, and decreased serum bicarb levels are the consequence. Signs consist of lightheadedness due to vasoconstriction and decreased cerebral flow, inability to concentrate, numbness and tingling from decreased calcium ionization, tinnitus, and sometimes loss of consciousness. Cardiac effects and respiratory alkalosis include tachycardia and ventricular and atrial dysrhythmias. Another good chart for you to look at is Table 13-6, which goes over the acid-base disorders and compensation, which is found in your text on page 271. Again, treatment, you want to, first, it will depend on the underlying cause of respiratory alkalosis. If the cause is anxiety, the patient is instructed to breathe more slowly to allow CO2 to accumulate or to breathe into a closed system such as that paper bag. So, like you've seen on TV, that actually does work. So we want to correct that cause of hyperventilation. Here are your normal values that are also pointed out in your chart on page 271. The main ones you will be looking at are presented here as your first 3 bullet points: your pH, your PaCO2, and your CO3. And when we're going to skip over the mixed acid-base disorders, but I do want to look a little bit at compensation, which we will go over mainly in class to actually give you an illustration of how the body will compensate. But the pulmonary and renal systems compensate for each other to return that pH to a normal value. In a single acid-base disorder, the system not causing the problem compensate by returning the ratio of bicarb to carbonic acid to the normal 20:1. The lungs compensate for metabolic disturbances by changing the CO2 excretion. The kidneys compensate for respiratory disturbances by altering the bicarb retention and hydrogen secretion. In respiratory acidosis, excess hydrogen is excreted in the urine in exchange for bicarbonate ions. In respiratory alkalosis, the renal excretion of bicarb increases and the hydrogen ions are retained. Likewise, in metabolic acidosis, the compensatory mechanisms increase the ventilation rate and the renal retention of bicarb. In alkalosis, the respiratory system compensates by decreasing ventilation to conserve CO2 and increase the PaCO2. Because the lungs respond to the acid-base disorders within minutes, compensation for metabolic imbalances occurs faster than compensation for respiratory imbalances. Now we will go over some IV therapy and IV selection and what to look for when doing IVs. We are going to skip over the portion in the text that goes over parenteral fluid therapy. Again, we talked a lot about them during the imbalances, but you won't have to know each of them, but know them if you hear them. Not so much, what it's used for, how much you can get, and if it's dispensed from pharmacy. We're not going to be that technical as far as your solutions, but you can skip over that information. Again, I will go over any important aspects, which we really did discuss within the imbalances, so we don't have to touch on that portion in the text again. So, onward to IVs. Now, with your IV site selection, this is in figure 13-7, which is noted on page 274 in your text. This is where you can start an IV. Of course, most often, ones that are used, I'll point those out. Usually your cephalic vein, your bacillic vein, those are the nice, juicy ones that we can see readily. Your intermediate antibrachial vein is also used use. The one that we like for labor and delivery is your basilic vein. We usually do not use the inside of the palm. We usually try to go for anything in the antecubital space if we can, or lower on, such as, let's see, your cephalic vein on the posterior dorsal side. Again, some of the metacarpal veins are used, but we try not to just because of the movement and everything like that. So one thing I do want to point out is if you are choosing an IV site, many sites can be used, but ease of access and potential hazards vary. Veins of the extremities are designated for peripheral locations and are ordinarily the main site used by us as nurses. Additional sites to avoid include veins distal to a previous IV infiltration or phlebitic area, sclerosed or thrombosed veins, an arm with an arteriovenous shunt or fistula, an arm with an affected by edema, infection, blood clot, deformity, severe scarring, or any skin breakdown. The arm on the side of a mastectomy is also avoided because of impaired lymphatic flow. So usually these patients that have an issue on one side or the other will have a sign placed in the room, or at least documented somewhere in the chart, that they are not to have any venipunctures or IV starts in that affected limb. So if you are looking for an IV site, make sure you take into consideration the potential effects on the patient's mobility when you are selecting that actual site. So you want to look at the condition of the vein as well, the type of fluid or medication that will be infused, things that we know will burn, such as your potassium, and things like that. We do not want to start an IV in the hand if we can avoid it. How long the patient's going to have the IV. Some hospitals say 3 days, some say 4, some say 5. So it just depends on the hospital policy. The patient's age, size, and activity level. So if the patient's really active, we don't want to put it in the bend of their arm because it's always going to be beeping or being occluded. Patient's age, our elderly population, some of their veins aren't as good or as pliable as the younger generation. That is another factor. You also want to make sure that if the patient's right or left-handed, so you want to look at that as well. Patient's medical history and their current health status and the setting in which the therapy will take place. We won't get too technical into the gauges or anything like that, just because of the simple fact that you will not be starting IVs, but I just want you to get a generalized idea. As an overview, you can look at chart 13-3, which gives you some guidelines for starting that peripheral IV infusion. And again, you will go over this when you get into advanced adult health, because that's when you will be starting those peripheral IVs, and then you will go into selecting your venipuncture devices, the cannulas, your needleless device system. So we're not going to cover any of that. I just really wanted to go over when you choose an IV site and actually what you're looking for when choosing that site. Another thing I want you to look at is when you are preparing that IV site. So before preparing this, the nurse should ask the patient if they are allergic to latex or iodine, products that are commonly used in preparing the skin for IV therapy. So you want to make sure your patient doesn't have any allergies to those materials. Excessive hair at the selected site may be removed by clipping to increase the visibility of the vein and to facilitate insertion of the cannula and adherence to of the dressings to the IV site. Usually we try not to choose any place that's super hairy. This usually is for those men that are super hairy. If you just like really cannot see it, then you may have to clip it, but usually you're able to see and palpate the vein when you put that tourniquet on. So these are some of your complications that you will look at. We won't go too in depth for these, but the one that I really want to point out to you is infiltration and extravasation, which is found in your text on page 281. So infiltration is that unintentional administration of a non-vesicant solution or medication into the surrounding tissue. This can occur when the IV cannula dislodges or perforates the wall of the vein. Infiltration is characterized by edema around the insertion site, leakage of the IV from the insertion site, discomfort and coolness in the area of infiltration, and a significant decrease in the flow rate. When the solution is particularly irritating, sloughing of the tissue may also result. Close monitoring of insertion site is necessary to detect infiltration before it actually becomes severe. Infiltration is easily recognized if the insertion area is larger than the same site of the opposite extremity, but is not always so obvious. A common misconception is that a backflow of blood in the tubing proves that the catheter is properly placed within the vein. However, if the catheter tip has pierced the wall of the vessel, the fluid will seep into the tissues and flow into the vein. So although blood return occurs, infiltration may have occurred as well. So if the IV is infiltrated, please stop the fluids, okay? And you want to start a new site and locate a new site. If you're looking at an IV that has infiltrated, we also want to look for extravasation. This is similar to infiltration, but it is a little different. It is with an inadvertent administration of a vesicant or irritant solution or medication into the surrounding tissue. So medications such as vasopressors, potassium, and calcium preparations, also your chemotherapeutic agents, can cause pain, burning, and redness at the site. Blistering, inflammation, and necrosis of the tissue can also occur. Older patients, comatose, or anesthetized patients with diabetes and patients with peripheral vascular or cerebral vascular disease are at greater risk for this because of the medications that they are actually receiving. So if extravasation occurs, the infusion must also be stopped and the provider must be notified immediately. The agency's protocol to treat extravasation is initiated. The protocol may specify specific treatments, including antidotes specific to the medication that is extravased, and may indicate whether the IV line should remain in place or be removed before treatment. Usually, the IV line is removed and another IV site is chosen. So when you are looking at an IV and it is running, note the site. If you do see that the site is infiltrated, your main concern is what kind of medication it was. And if you determine that it was one of those high-risk medications, your main concern is then extravasation if the medication actually went into the tissues. Also note that if there's swelling at the IV site, you're going to make sure that you document that the IV infiltrated. It is not putting you at fault that the IV infiltrated. You just want to make sure it's documented. You remove that IV and restart in another location. And again, please ask your patients if they have allergies to latex or iodine prior to starting an IV, because some of the items that are used may contain these products. And as for the rest of the chapter, that is all I wanted to cover as far as IVs. So feel free to read over the rest of the information if you would like. Other than that, that will conclude chapter 13, which goes over fluid and electrolyte imbalances or balances and disturbance.